Hi everyone, my name is Yesin Tan, and today I will be giving you my take on a very short yet very powerful book named Dying for a Chat, written by Dr. Ranjana Srivastava. Dr. Srivastava is a medical oncology physician based at Monash Health in Melbourne, whose work has been published in various high-profile journals, including The Lancet and the New England Journal of Medicine. The topics that resonate through her work include medical ethics and the importance of maintaining patient autonomy, and Dying for a Chat focuses strongly on these issues. The book is divided into two main sections. The first tells the story of Mrs. Johnson, a vulnerable 90-year-old patient who was subjected to a series of unfortunate and unnecessary events that led to her death. Her story illustrates some of the major ethical issues in our health system today and are discussed in more detail in the second section. The author also raises some possible solutions to these issues and how they might play out in today's environment. This flow diagram illustrates the course of events that Mrs. Johnson endured, beginning with a seemingly simple presentation of pneumonia, where oral antibiotic therapy would have well sufficed. Instead, she was cannulated and given intravenous antibiotics because, as the resident doctor said, I guess she's here, she might as well get some intravenous stuff. A prolonged IV access resulted, leading to a skin infection at the IV site, which again warranted further antibiotic treatment. Several days pass, and fortunately the skin infection improves, but as a result of a potent combination of medication prescribed by various medical specialties, Mrs. Johnson goes into acute renal failure. She is admitted to ICU, where she receives the whole shebang of medical technology, including artificial ventilation, dialysis, parenteral nutrition, with no signs of improvement. Up until this point, there has been no discussion with the family or patient about an advanced care directive, about what the patient would want in the event that they don't get better. And this discussion has been avoided so far by a variety of factors, including a lack of one-on-one time between the doctor and patient and a lack of confidence and experience by more junior medical staff in how to approach this difficult subject. Finally, there is a decision made by the family to withdraw care following the advice of the ICU doctor. She does not die straight away, and unfortunately suffers another 24 hours in a situation the author describes quite rightly as just wrong, and questions, was it my fault? How is it that doctors charged with helping people end up harming? The second section discusses the complex issues that were raised. 1. The demand for a better, more coherent health service for an ageing population. 2. A healthcare system that is fragmented with over-specialization and insufficiently coordinated care. 3. Satisfaction of service through individualized care. And 4. The risks of inappropriate and unnecessary tests and treatments. Let's discuss each of these in full detail. The author quotes that by the year 2050, the median age of Australians will be close to 50 years of age, with life expectancy for men and women to rise to 92 and 95 years of age respectively. We are aging all too quickly. The predicted rise in the burden of various chronic diseases is terrifying, with a 200% rise in diabetes and dementia and a potential 75% rise in cancer rates. The author raises this important point of the need to establish a more coherent health service, one that integrates the services of various providers for the same patient better to provide more seamless and better holistic care. And she's absolutely right. Aged care is already a primary focus in the health budget, and divisions of the Department of Health on the care of older people in hospitals is an example of a leading directive to provide support and avenues for research to improve health services for this population. The author recognises that we live in a day of age where seeing a specialist is quite the norm. With the increasing autonomy of patients to seek secondary medical opinion, it has created a health system where it is no longer expected to receive truly comprehensive care just from one GP. There is nothing wrong with specialties. In fact, the author raises some very notable points that the medical field strongly encourages specialisation. In addition to a higher salary, it is a sign of career advancement and draws respect within the profession. There are, of course, patients who genuinely do need specialist care. But the issue is in the lack of integration of specialist care with overall care and the overmanagement of those who simply just need a good general doctor. And this can put patient safety at risk. There are various pieces of literature that validate this point, and it was reported that in 2011, the number of medical specialties and subspecialties was approximately 6 times the number of those in 1960. And with further medical and technological advancement, this is likely to grow further. The author touches on this issue through the example of Mrs. Johnson and how the lack of an individualized approach to help her understand her options contributed greatly to not just the outcome of death itself, but also to the immense dissatisfaction in the health care that she received. The author states that some of the barriers to individualizing care include 1. Doctors' fear of repercussions of not providing a sufficiently aggressive enough treatment, especially from family members. 2. The presence of enticing advances of modern medicine that cloud judgments of honest clinical benefits. And 3. The shortfalls of communication between doctors and patients about sensitive topics surrounding realistic health outcomes. Ultimately, the point is, even if Mrs. Johnson's outcome was going to be death, regardless of the quality of care or decisions for treatment, the author reminds us that satisfaction in one's care is imperative. In fact, to validate this argument, patient satisfaction has been recognised by the National Safety and Quality of Health Services Standards through the recognition of the importance of consumer engagement in developing hospital activities, allowing the public to have their say about how their health service should be provided. In the case of Mrs. Johnson, we recall that she received IV antibiotics instead of oral antibiotics, which would have been appropriate for her severity of pneumonia. The author reminds us that with every treatment option, clinicians must consider the cost, the impact on patient comfort, the possible adverse reactions, and the likely clinical benefits of treatment. Do the benefits outweigh the harms? In practice, this is indeed becoming a particularly hot topic, especially in emergency departments amongst Victorian hospitals, with projects looking closely at IV cannulation and encouraging clinicians to think twice before they cannulate. So what does the author suggest can be done about these issues, particularly to improve patient satisfaction in healthcare? The author provides an insightful opinion on the pros and cons of the following possible solutions. 1. Increasing funding to provide more resources. 2. Producing more doctors who would then have more collective time to address patients' concerns. And 3. Addressing the public health message of empowering patients to be better informed and thus better prepared to interpret the information provided and better equipped to make truly informed decisions. The author advocates for a solution that recognises that one of the primary drivers of dissatisfaction with healthcare is poor communication between doctors and patients. In a recent literature search I conducted on this topic, I found several relevant papers that confirm that communication between doctors and patients is and has been poor for quite some time. A 2004 guidance document produced by the Australian National Health and Medical Research Council stated that in repeated findings in health complaints boards and medical boards, poor communication is the catalyst for most complaints. In 2013, the Healthcare Complaints Commission confirmed in its annual report that communication was the primary cause for complaints in 21% of those reported. The author suggests that by focusing more efforts on training all medical professionals to become better communicators will enable them to provide a higher quality patient-centered service. The author admits that there are various hurdles to this type of approach and recognises that communication is not a particularly exciting topic. And in a world where it is already so difficult to keep up with the latest medical advances, communication hardly seems like a topic of priority. But the author discusses with promise that internationally there has been a shift in the approach to training doctors, with the University of Chicago now emphasizing training on helping doctors become not just better diagnosticians, but better advisors and counselors to assist patients in making difficult decisions. The author encourages that we must change our view on communication skills completely to recognize it as an area of continuing professional development and as a crucial skill required to provide a necessary patient-centered approach. This is supported by the literature, and there is a body of evidence targeted at improving communication and trust in health professionals. But the challenge remains in developing an intervention that works and is sustainable, and much of that research has reported conflicting evidence. Overall, Dying for a Chat is a powerful book that raises some key issues with proven local importance that threaten the integrity of patient-centered care in Australia. The author has demonstrated a thorough and insightful approach in her critique of where our health system falls short and boldly encourages a shift in our recognition of communication skills so that stories like Mrs. Johnson won't happen again. Thank you for listening.